Hello and welcome everyone for tonight's EAO Just Ask. Tonight it's a pleasure. Oscar, I think you need to reduce the volume, please. Because we hear you double. Okay. Sandra, can you help us with that? Okay, so again, now we're here. We had a little bit of technical problems, and it's great to have Oscar here, Oscar González-Martín. It's not only nice to have you here, Oscar, because you are a true friend, and it's so good to have you here. And with this, I would like to welcome you on behalf of the EAO, and also at the end of the year, I just heard it's the last thing of this year's. So with this, Oscar, thank you for being here. It is a great pleasure. Thank you very much.
Thank you so much. The pleasure is mine.
So tonight it's we're talking about superstructures, and Oscar, I mean, I really don't need to introduce you. You're one of the top experts all around the world. You just came back from New York. I heard you were lecturing in New York. It's just amazing. You did your degree in Spain. Then you also had some time in US. And you have your PhD degree. So it's just amazing. And you also wrote a book, I just heard, for children's, and you donate everything what you get from this. So this is just great to hear this. We welcome you on behalf of the EAO. The topic is how to construct your implant superstructures today. Again, Oscar, thank you for making this possible for the EAO. We're very happy to have you. Welcome again.
Thank you so much. Now I'm looking forward to discuss about this topic.
Oscar, just a case ran through my clinic today, and I thought I have the expert with me tonight. And you know, I'm a periodontist. I'm a little bit cross-trained. In US, we always say we're cross-trained, but please be polite. I follow your rules. I am a little bit a fan of yours. You know this. What do you say? Did I do it wrong? Did I do it right? What do you say? Is there room for improvement? Just give me 2-3 sentences about this.
No, I think it looks fantastic. I see a few things that I like it very much. I see that you have a zirconia base that is well polished. What I understand that there is no stain below that or ceramic, that the ceramic it will start just in the mucosal margin up, and there you can do whatever you want. You can stain, you can use different type of ceramic, but you're respecting that. Also, I can see that what we call the subcritical contour, the more deeper area of the suprastructure, is as reduced as possible, which is allowing for the tissues to be stable over there, to stay long term, and I can imagine that this screw retain restoration too, which also it follow what we are doing today. 20 years ago or 15 years ago, we were still discussing about this screw retain or cement retain. I think today there is no discussion anymore. We just go cement whenever there is no more options, pretty much. But most of the time we try to find a way to screw retain or restoration. So yeah, I like it very much. And then as we will see later on during the small lecture, I think it follow what we understand today is modern implant dentistry.
I follow your rules. That's what I did. I'm happy that you like it. And now, Oscar, we're all so eager to learn about your knowledge. I mean, for me, you wrote one of the keynote publications, the landmark publications. It is a little bit, it hangs over my bed. No, I'm kidding, but it's a very nice publication. I recommend everyone to read it. We already also have a lot of people already logging in, people from Tokyo, we have people from Venezuela. We have also the president logging in. Jill is logging in. Jill, hello. It's a pleasure with people from Switzerland. And with this, Oscar, the whole world is looking at you. I know you're used to this.
No pressure.
No pressure at
all.
No
pressure.
We are happy to look at your presentation. I know you know that it's a little bit the routine here. That I interrupt. It's not unpolite. It's just because I'm interested, and sometimes we have the feeling that people don't ask. So I will interrupt. It's not unpolite. I know the Germans are sometimes people think they're unpolite, but it's not. It's just interest. Oscar, we're looking forward to your presentation.
I will be more than happy. We are two friends talking about the topic, and that's how I see that. So. The presentation itself, I don't want to be like a really a speaker today. I just want to share with everyone some ideas, just to bring some questions, and that's the whole thing. So, implant superstructure today is an important part of the restoration, especially this space between the mucosal margin to the neck of the implant is 4, 5, 6, 2, 1 millimeter, depending the depth of the implant. And the type of the implant is a key factor in the result of the treatment, and of course it will interact with the peri-implants of tissues, and also sometimes even with the hard tissues, depending on the depth of the implant. So it's crucial to be able to somehow create something that is going to be, or it was going to be looking at two different or main objectives. The supracrestal component, in my humble opinion, has two main objectives: to create a biological seal, to be healthy, to isolate the mouth environment to the implant, and of course, to create an aesthetic outcome that is going to be fulfill the requirements of the patient. The truth is that the relationship between the peri-implants of tissue and the abutment itself is not a very strong link. And the best of the scenario, we will have some hemidesmosome, not even in every single case. And the connective tissue, it will embrace with a functional orientation of the collagen fibers. So at the end of the day, we don't have a real attachment between both of them. We can discuss about that. And I have this discussion with few people in the past, but no matter how, is a weak link between both of them. So even if it is weak, we have to have it there. So we have to take into consideration a few things. And finally,
maybe a first question. You're talking about the seal, which is on the abutment, right? But sometimes we also have a hybrid type of implant, or we have an implant where we maybe have a sort of a bone remodeling. Would you also say that there is a hemidesmosomal attachment on the implant per se? You understand my question?
Sure. Let me tell you.
That's a tough question to start.
Oh, no, it's not tough. I don't have a full answer for that, because you can find literature in both sense. So you have literature that, especially for some implant brands, that they try to prove that they have some type of attachment over there, but then you always have this feeling that maybe it's commercially driven. On the other side, you have some other people that they are proving that you will not have found this particular hemidesmosomes over there. So the reality is, do we really need that hemidesmosomes? Do we really need that? I think that we should be the question. As far as the peri-implant soft tissue is stable, has enough width, and is thick enough, and I think, as we can see more and more in new papers, that the result should be stable long term. And with that, what is going on histologically, it will be very nice to know, but I don't see a clear answer for that in most of the situations.
Okay.
So aesthetically, of course, we should achieve a superstructure that it can interact with the gingival margin, but also with the volume of the tissue. But finally, with this peak of papilla tissue that sometimes give us some nightmares. What are the factors? What are the factors that not only influence the health, but also the aesthetic of the peri-implants of tissues? I always share these two papers because they are for good friends, and they did a nice literature review, systematic review or meta-analysis of what has been published until a few years ago. And they review all the literature in prosthetic dentistry, in implant dentistry. Unfortunately, and we have this discussion before we were live, right? That the implant pros has been not very well taken care of in the previous 20 years. Most of the literature has been focused in the surgical part, and unfortunately, the pros part is something that for many years has been almost neglected. So the transmucosal component that they analyze are these four: the material of choice, which is the material they use for the superstructure. What is the surface topography? How do you contaminate that, and how you make the shape of this particular area? And it's quite interesting to see this resume. Pretty much a microscopic design, surface topography, the manipulation of the implant did not have a significant influence in peri-implant inflammation on them. And I always say the same. I mean, really? No, absolutely not. The truth is that we don't have evidence. We don't have scientific evidence for many reasons. But one of them is today dentistry doesn't allow us to do studies that you can create a group that you certainly know that is going to be a damage situation for the patient. I cannot place a dirty provisional or dirty crown in a patient just to control that it's going to have an inflammation. So we have an absence of evidence in many of the things that we are trying to prove, and that's why the clinical expertise is getting more and more important in the last few years. But about the material of choice, we have few ideas, and we are getting more interesting topic because we were also talking before that many times we ask for a implant crown, and you don't know what are you receiving. This is zirconia, this is lithium silicate, this is a titanium base or doesn't, or which type of, this is a stain, or we are doing a porcelain here. And basically three material choices: titanium, zirconia, or gold alloy. That's the gold alloy is almost out. It is out for many reasons, but even there is some scientific reason behind that. Is getting you more inflammation and worse attachment condition when you compare to the other two. So although these precious materials were very well received for dentistry 20 years ago, they don't have more space today.
And it's too expensive now, right?
Absolutely. I mean, there is
maybe we can do the abutments in Bitcoins, so it's all the same.
That would be nice.
No, I just have a very serious question. Do you think the worse prognosis of gold abutments? I mean, you probably also did a lot of UCLA abutments. Do you think this is because of the material, or because of the weakness to polish the gold material sufficiently?
It's a great question. It's a very good question. The truth is, I think both things can play a role here. And the truth is, maybe I did my last of these cases like 15, 20 years ago. So I don't have much experience lately. And basically, we have two options today, which is a titanium or zirconia or both. And more than the difference in the color or the aesthetic, and both are fully biocompatible. the truth is we're starting to have some papers out there that they are telling us that we can find more bleeding on probing and inflammation around titanium than zirconia. I will not say that will be something like a determinant, but the truth is every time I have a very difficult case or I have a very thin tissue, either I try to enlarge that amount of tissue surgically, or I choose some zirconia base there. Of course, I always will have a titanium base where I screw, but I like to have some submarginal zirconia that is going to give us a situation like that. I don't see that around titanium.
Yeah.
I don't see that around titanium.
And Oscar, is that because of the material again, or is that because I can just get zirconia smoother?
Well, titanium can be smoother too.
Mm.
Titanium can be smoother too.
So you think there's something in the zirconia which is just better for soft tissue?
I think so.
Mm-hmm.
I think so. I cannot prove it, and there is a few papers out there that they are getting more and more information about that. But the truth is, I don't see that around titanium bases. I don't know if you have seen that around titanium, but no, not quite often. And I have seen this several times around zirconia.
Mm.
So, what about surface topography? Basically, what we know is something that is, even now we all have that in mind. 5 years ago, we didn't have this so clear, but that basically whatever is below the gingival margin or the mucosal margin has to be polished. It was not like that. I have placed hundreds of crowns with ceramic down there and beautiful stain below the gingival margin. I did that. And the truth is that the adherence of the epithelial cells are going to work better when the surface is smoother. And not only that, when it's not smoother, the bacteria love it. So now that's something that we really know, but I'm sure you have placed also some crowns in the past that, you know, the lab technician did this beautiful job just in that area. It took the time, very artistically. Actually, there is papers out there that they try to compare polish with rough, because we thought, and it's very logical to think that you see, if it is rough, the epithelial attachment they have the possibility to be better attached or more related to. Sense. We do that. We do the same for the implant, right? We make the surface rough, you know, to create more rotations there. But today we are clear on that.
So can we make it simple? We talked about recipes. Bone loves rough, soft tissue loves smooth.
Yeah, I like it. I like it very much.
Or let's say epithelium likes smooth.
Yes,
let's put it like this.
It will be like that. Yeah. And bone like rough. Yes, they like it, but also bacteria like rough. So you know, it's that's a different thing.
That's true.
That's another discussion. And the truth is, all the papers that we have out there, most of them are focusing final restoration. We didn't care about the provisionals at all, and because it's the little brother, you know, it's like the ugly duck. So, but I think we can learn a lot about the provisional restoration. So I would like also to focus on how to play with the provisional restoration, because it's again a different material. It's plastic. It's something that we put in and out several times. So what about the disconnection? And also, it's our responsibility to play with the chairs, with the macrogeometry. It's our task as a dentist. It's not we cannot blame to the lab technicians for that. It's ourselves. So how to play with provisional restoration? To make the story short, because I promised not going to be a lecture. Basically, I always told that for me there is 3 items in the in the macrogeometry of the prosthesis, not only the provisional, but also the final, the cervical contouring concept from the Chacho 20, almost 30 years ago. I mean, amazing that it started to give us the ideas about how to create that. The transmucosal, the concave transmucosal abutment a few years after, and then the critical and subcritical contour that we published in 2010, 2020. And basically, the idea is to try to replicate, the original idea it was to replicate the shape of the tooth, but then we realized that this doesn't work every single time. That the peri-implant tissues is not the same as the periodontal tissues. So even it can make sense to try to make exactly the same shape that the tooth that you want to change or you want to replace. It doesn't work every time like that because you need requirements for that. It is only going to work when you have an excess of tissues. But also, most of the times, to create that from zero is something that we have to control ourselves. To jump from something that is close, like you can see here in the left, to something which is in the right, step by step, I think it's something that we should do, controlling what we are doing, right? Because if we jump from zero or from something so small to something so over contour, with a full contour, at the end of the day, what you're going to have is a lack of control. Yeah. It can work, but most of the time, especially in the anterior part of the mouth, you're losing that control.
Oscar, is there still a rule of thumb? I learned if the ischemia after the pressure of the provisional is more than 10 minutes, it's too much. Is that still a rule of thumb?
Well, there is as far as I know, there's only one paper out there. I think the last author is like one, talking about the most of the time the ischemia will disappear between 10 to 12 minutes after you insert it. You have to understand that vascularity around implants is reduced. It's more than like an scar tissue. So I can talk you what is my rule or what is my receipt in my clinical practice. It will be that if I put a crown, provisional crown or final crown, and after 12 to 15 years still have some ischemia, of course it will be reducing after that time, it still have some ischemia, it's too much pressure for me, I will remove it, I will reduce a little bit those contours, because especially for the provisional restoration, what you want to find after 2 weeks, if you check your patient after 2 weeks just to see what's going on, you will still have some inflammation around the gingival margin or the mucosal margin. So at the end of the day, you're losing time because you don't want to do anything if you have an inflammation. So I prefer go step by step with that. Okay. So when and how we should apply the concept?
Okay, can I have one more question? Sorry, it's so interesting, my friend.
Yeah,
just a question to the provisional phase. I mean, now I'm doing so much effort on the final reconstruction. I'm doing zirconia, I polish it, I do the contour, following your rules. And then I always think to myself, now I do a provisional, I put a little bit of flowable composite in the subcritical and critical contour, and I place it. I mean, is that allowed, or don't you think it's a problem, or is that only because it's short in the mouth? You see my point? It's a little bit. I mean, the one concept is try to control everything. On the other thing, you use a material which is maybe also with the rest monomeric stuff. It's maybe toxic for the cells and whatever.
No, it's true. The truth is we have both sides. I mean, because also we can see many soft tissues studies in soft tissues that they like the composite or even in the past or some other resin materials. The question is how you treat that. What I make sure every single time we're gonna insert a provisional restoration after I change or I add some composite, I extremely polish that.
Yeah.
I always give one recommendation: you polish once, twice, third time. Whenever your hands are burning, you polish again. So it has to be extremely polished. because the last thing that you want is to create an area that it can be colonized by bacteria, and at the end you can have also an issue there, especially for immediate implant provisional restoration. That's the last thing that you want to have. But the truth is, we have been doing that. I've been trained by Professor Urs. He played with provisional restoration with every single case that he was doing, and with a very good success. So I always say it's not what do you do, is how do you do it in this particular.
But I got the rule of thumb. Okay, 3 times until your hands are burning, and then it's fine.
You have to polish quite well, yeah.
It's a little bit like Kelly told me one about flap releasing. He said, when you think you're finished, release 30 minutes more. It's a little bit...
Exactly. It's pretty much the same. It's very scientific, as you can see. It's very, I can share with you a lot of science about that.
I like that one too.
But that's... And the truth is, I always like to differentiate between 2 different scenarios. The prosthesis that you're going to place in an immediate implant and the one you place after osseointegration, they are different animals. And actually, they share the name, but they should be called differently because they are both implant-supported crowns, so implant-supported restorations. But the truth is that they're looking for absolutely different things. When we are thinking about immediate implant, basically that provisional is looking only for one thing, to support the soft tissue architecture. Otherwise, you will lose that information because the soft tissue will collapse. If this is a dramatic thing, absolutely not. Absolutely not. If you know how to give back that information after integration, it takes longer, but absolutely you can do that. And for that, if you want to keep it, you want to design a prosthetic contour that you have to do a few things. The first thing is just to hold the tissue, or even to give some space, especially if you're trying to do any type of graft at the same time. And that's crucial. Many times we do a beautiful surgery, beautiful graft. We are very careful, and then you put a terrible crown on it, and you kill half of the tissue. Yeah. So unfortunately, this is something that we see quite often. That's why it's very important to customize our provisional restorations. And the second thing is to avoid soft tissue compression and immediate implant provisional crown, because that's the last thing that you want in this particular situation. You want to hold the tissue without creating any type of ischemia. Anytime I place my crown and I see this type of ischemia, I know that I'm pushing too much. So basically, at the end of the day, I'm looking back what Eric Romper used to say, the concave profile provides more stability to the tissue than the diverted and the convex one. So at the end of the day, you are trying to reduce as much as possible. And that has been proving very recently, 2022, and listen, 2022. This is yesterday.
I know.
So we have been doing provisional crowns or final crowns for 60 years, and not until 2 years ago that we proved something that was published 15 years ago. That's my point. My point is that prosthesis has not been pretty much taken care of, and then the numbers are amazing. I mean, if you make a convex profile, you will find a recession in 65% of the cases. While if you do a concave profile, you won't go to the 14. So it's a different ballgame. So it's important to keep into consideration. So I'm not going to go to...
Can I have one more question about this? Because absolutely. I think this is so important. I think we will talk about this in a second, but still, I am coming a little bit from recession coverage, and there it is very important is, of course, not to have too much pressure on the soft tissue. But still, I mean, if, for example, if you have a cervical lesion, you also lose tissue because it sort of falls in, and you lose contour. So for me, it's extremely difficult in that concept to at the same time be concave, but at the same time hold insufficient soft tissue stability. You get my point?
Absolutely. Because this will come to the point where we have to make two different areas of interest, which is the critical and subcritical. What happened with a non-cervical, non-cardiac cervical lesion is that most of the time you're losing the stability just because of an excess of concavity. And then you have problems because there is no
also the scalloping. You lose the scalloping.
Absolutely. But if you take a look here, the difference between concave and convex is that what we call the critical contour, that we will speak about that in a second, it will still hold the gingival margin. And whatever happened below that, most of the time we'll be filling with biomaterial, and most of the time that's what we want to do, or with a soft tissue. So basically, we will have enough room just to create that space over there. Actually, we are starting with my friend Mario Beltri and a study right now just to measure in a volumetric way this particular area there. And I hope we can have this data soon. So this is important. We will create a gingival contour which is flat or concave, never convex, because if you that's what you want, this to create this green area over there. That's what we are measuring right now, and to create this green area is is crucial if you want to create something. Actually, we call it the regenerative space, but it's a wrong name. It's published this way. It was my friend Ignacio San who told me, I don't like that name. I said, listen, I published that already. Because we are not regenerating anything. That space was full of a tooth, and we're not creating a tooth. So the term itself is not very well created. I have to look for something different. But the green area is important because it's going to have a coagulum, we're going to have a biomaterial, we're going to have a soft tissue over there, and it will become tissue. That is the goal. But in the contrary, if you place that in the mouth, you're dead in the water. But
still, Oscar, I mean, if you go back one more picture, sorry for interrupting, because it's so important in my perspective. How can I know that I might not get a millimeter of recession? If I get a millimeter of recession or tissue collapse, I might lose support. Or how do you see this?
The truth is, I mean, you never know that. You never know that. It will depend on many other factors.
Right.
How thin is the original tissue? What is the phenotype of the patient?
How is the healing?
How well, absolutely. How well you are holding the critical contour? How well you're holding that? If you don't hold that in a proper way, then most of the time you will have a collapse at the end. It's pretty much the same that you see in the non-cardiac cervical lesion. It's pretty much a pretty similar situation. That's why to hold the critical contour is crucial. To hold it in a nice way. Only in certain situations, I allow for a 0.5 millimeter of space. And that only happens in cases that I have a previous recession and I'm making a soft tissue graft. Then I allow for a small space so the tissue can move coronally in that particular situation. Otherwise, I will hold it.
So you compensate for that?
Absolutely. Absolutely. So, but on the contrary, if you place in the mouth something like that, you're occupying all the space with composite. Don't. You can make the best soft tissue graft in the world. You kill the space. I mean, you're not respecting the surgical principles for that. So, three main objectives for an immediate provisional restoration: maintain the soft tissue architecture, avoid soft and hard tissue compression, and allow for this space for the regenerative process, or whatever you want to call this green space. However, after the maturation of the soft tissues, after the osseointegration, you can have situations like that. Everything has been perfect, ideal, and then you just copy that and send to the final. That we can discuss how to copy that. That we published that paper in 2020 that was very well received about the inverse scan body, and then some companies call it reverse or scan replica or whatever. But other times, listen, I did my best. That's what I get. I mean, I promise I did my best. And I have a collapse, and I have a minor recession, and most of the times today, especially today that we are getting better with mucogingival surgeries, we are trying to compensate that from a surgical point of view, but sometimes the tissue is there, and we need to know how to play with the tissue. So how we modify the prosthetic contours, that's an important word, because always you use this word over contouring, under contouring. I don't like to use these words, because when we think about a crown over a tooth, to over contour that is something that doesn't fit. It's something that is in implant dentistry. I would like to talk more about adding contour or adding volume or reducing this volume. And basically the rule is, if you over contour a crown below the gingival margin, the soft tissue margin is going to go up. If you reduce, you may have the possibility that this soft tissue goes down. Depending on many factors, it will have a limit. The amount of tissue, the thickness of the tissue, also the interproximal soft tissue peaks. So at the end of the day, there is a point that even if you reduce as much as you want, the soft tissue is not going to move coronally anymore, and then you can think in compensating surgically. But is where we published this particular paper, the critical and subcritical contour, in 2010, because we find two different areas in this transmucosal component. The critical contour is just the area of the gingival margin below the gingival margin, this millimeter that hold the gingival margin, that has a particular function. And from there to the neck of the implant is what we call the subcritical. And the subcritical contour is also the platform. Altogether is the subcritical. You can modify it or not, but at the end of the day, the shape is all the same. So the subcritical contour is from the neck of the implant to the critical contour. That's why this is a macroscopic design. It's not talking about material of choice. No, it's about shape. And the critical contour is the more superficial. And basically what we try to do is to play with the zenith or the gingival margin, and then you know how to do that. We see this patient every 2 weeks. We add a little of contour over there, and we try to create an area that is going to have an impact in this more superficial area. And the subcritical, as concave as possible, always the same. And this is what we are able to create after some follow-up.
Oscar, I have a little bit of a polemic question. You know me, I always have to put a little bit the finger in the wound. A fantastic result. But you hear sometimes people saying, this is a concept which needs to remove the provisional a lot of times. Is that a problem? You know, talking about one abutment, one time, disruption of the soft tissue. I do it the same. I recontour it a lot of times, but I always feel a little bad. So give me a little bit of confidence.
No. Actually, like in few slides, you will see what I think about it, but I can answer now. The literature is not conclusive. You can find papers that is telling you that you will have some bone marginal level if you put in and out your provisional several times in a short term. When you take a look of the same sample, 4 or 5 years follow-up, there is no difference between one abutment one time or removing these crowns a few times. So the truth is, let's think biologically. One abutment one time make a lot of sense. We'll never discuss that. What do you want from one abutment one time? To create an environment from the connective tissue that will be a stable long term. Does it? You don't disrupt that anymore. Yeah. But it's true that the connective tissue is not going to be attached to your abutment. So
even if they show sometimes picture where it bleeds when you remove and so on.
Yeah, but this bleeding, it can come from either the epithelium, but not from the connective tissue, or from an inflammation.
True. That's also what I always say.
No, I mean, otherwise we have to prove the connective tissue is attached.
Yeah, got it.
So, and listen, I love this conversation and I like this topic because I'm not very categorical on that. The only thing I can say is, again, is I use it before and I use it again. Is not what you do, is how do you do that?
Yeah.
If you want to place a provisional restoration that is dirty, that the macroscopic design is wrong, you're creating an inflammation.
Yeah.
Several times. If you're going to do that few times during this process, of course that inflammation is going to lead to a bone, marginal bone loss. Of course, there is no question about that. If you have a very thin phenotype and you're disrupting that several times, of course you can have an issue there. But if you have an environment that is correct, if you know what you are doing every single time that you are removing some of these crowns, listen, otherwise, most of the pros guys will see problems in every single case.
Yeah.
Because we modify our provisional several times, most of us. If one day I can do abutment one time very feasible way, not with an intermediate abutment that it will prevent me to play with the soft tissue, because that's the reality, I will buy that. I will be the first guy to go for that, because the concept, the balance between biology and aesthetic, of course, the biology is always the most important part over there. So that's what I think. And
so we're back in the hot fingers during polishing, right?
Yeah. And the concept about how to push the tissues, how to play with it.
Yeah, great.
Also, it's not only about pushing, but also you can reduce also some of the contours, especially in the initial. Let me take this out because I think I lost the battery here. Can you hear me well?
Yeah, perfect.
Yeah? Mm-hmm. Perfect. So in a situation like that, also, if you have an excess of pressure, you just can reduce this excess of pressure, especially in the first stage of the healing, and the tissue, it can move down to certain levels, to certain limits. This is not Harry Potter that suddenly, you create a lot of tissue. That is not going to happen.
Yeah.
So, but then there is another area, which that was the main interesting part for this particular paper. No, was not the critical, it was the subcritical, because up to that point, we never pay attention to that. And at the end of the day, I fully agree with Eric Rompen, our co-worker, that every time I can, I will go as concave as possible. But also, there's a number of situations that we need to know how to hold the tissue adequately. We go back to the situation you're talking about, the non-cardiac cervical lesion. You don't hold the tissue adequately, you have a bad result at the end of the day. So the subcritical contour is this deeper area that it can be very concave, but sometimes it can be a little bit plain or flat, and in sometimes, depending the position of the implant, it will be even a little bit convex. In all these situations where the implant is so palatal or so lingual, and then I have to feel a large way to hold the soft tissue, at the end of the day, you have something which is an ovoid pontic pretty much most of the time, which is convex.
Yeah.
So if you want to do something like what you see there, I didn't do any connected tissue graft. I just moved the tissue from the palate with a provisional restoration to the buccal. So the tissue is there. Yeah. I could think to do a connected tissue graft too, but even if you have an excess of tissue, you need to know how to create a profile anyway. So the critical contour is this more superficial area that you can see in this beautiful image that Dr. Ballesteros gave it to me. And in the subcritical contour,
that is the most superficial. So critical contour CNIT, position of the margins to critical contour root convexity as soft tissue colors. That's what we're going to obtain. And we published this 2020 paper with these two tables. Immediate implant provisional restoration, critical contour. It will hold the tissue, or you can leave a small space. Subcritical, as concave as possible. You want room.
Yeah.
But after the soft tissue integration, after the osteointegration, you have different scenarios.
Yeah.
And then you need to learn how to play with those tissues. That was your question. What is the real impact of multiple abutment connection? And of course, I have to defend myself here because I like to play with my provisional restoration. So you find papers that give you a negative effect of marginal bone levels in a short term when you place in and out. These go to a neutral effect in a long term. And then you find some other papers that they compare one abutment one time with 3 times put it in and out with no clinical relevance on that. Again, it's about how, no? It's all about how you do that. And a couple of things more, and we are right in the end. Now, this is a new topic. People is trying to measure what is the angle, what is the emergence. And we have this paper from Gallucci a long time ago that he is just one single case that he showed that if you go too convex with this particular abutment, the bone is gonna run away from there. On the contrary, if you go flatter and more concave, you will find a different scenario. And I'm sure that I agree that we will see that in several situations. But which is important for me, is that you have to create something that still you need to have some ability to be clean and out of inflammation. And of course, there is an influence of this. In particular, I'm not sure about these angles. I'm not so happy about this measurement because it depends on many factors. It depends where the implant is, how deep it is, how big is the area that you need to restore. So for me, it's very nice topic. It's something that we should keep researching about it. But today I don't find a conclusive restoration. In my opinion, you need to respect the connective tissue area. And
so it's a little bit the 30 degrees angle we're sometimes talking about, which may be a risk factor for peri-implantitis. Is that what you're talking about?
Yeah, I'm talking about that, and I'm not saying that I'm not against that.
Yeah,
I'm just saying that in many instances you have no choice depending where your implant is.
Yeah, true.
And you have to restore it. So even though you have certain situations, you will need to create the most respectful restoration that you can.
I mean, also, if I remember these papers correctly, with these 30 degrees, they also emphasize that if it is concave, the subcritical compartment, the issue is not that big of the angles.
What is the problem when your implant is too buccal?
Right.
Then everything is a problem.
But leave the space for, well, how do you call it? I like it. Regenerative space. I like it.
Oh, okay.
I have to talk with Nacho. I like it.
Okay, that's good. That's good. So this is what we are trying to talk about. And now you asked me about this, right? We should go directly to the implant platform. We should work with these intermediate abutments. The question is, for single implants in the aesthetic zone, the intermediate abutment is not always a very simple situation because many times the stock that we can find is not very well thought. So the design is not always very feasible. Of course, there's only one thing that we have to keep into consideration. If you take a look here and you put an intermediate abutment, most of the time you're reducing the possibility of playing with the provisional restoration. Right. Which I'm not against that. You just need to know that if you place that, then forget about to play with the critical and subcritical contour most of the times. That's it.
Right.
If you don't need it, go for it. Go for it. Okay. So basically, it's a balance between biology and aesthetic, and to finish my this topic, the limitation of the design of the emergence profile. The limitations are influencing for three factors, in my opinion. The first factor that influence the macrogeometry, it will be the three-dimensional position of the implant. We published that in a paper from 2020. Depending the buccolingual position and the apicocoronal position, the shape is going to be completely different. And we have limitations there. Especially when the implant is too superficial, basically the subcritical contour doesn't exist. So we have to keep that into consideration. The second thing is the abutment platform. So whatever abutment platform you choose, it will prevent you to, or it does not allow you to play with the soft tissues. So basically, if you choose in an implant of 4.5 millimeter below the gingival margin, if you choose a 1.5 millimeter abutment platform, you have room for the critical and subcritical. However, if you choose a 3.5 millimeter platform, the critical is the platform. The subcritical is
like a multi-unit.
Yeah, so it's okay. It will be very nice from a biological point of view, but you cannot play with the soft tissues.
Right.
That's it. On the contrary, if your implant is deeper, then you may choose a larger platform there. So,
but then you have a deeply placed implant.
Absolutely. That's a different ballgame. That's, And finally, the peri-implant phenotype that Gustavo Avila and Emilio and Homley and myself, we published a few years ago. And in those situations where we are in the red level here, where in all these situations where we have not the best soft tissue around it, then we have always to consider to surgically compensate for that. Then maybe the provisional restoration is not going to be enough. So we have to be very, very careful when we create our emergence profile, but always to consider to make a soft tissue graft just to compensate for that. So that's pretty much what I have for sharing with you. I don't need to do any conclusions. For me, whatever you are happy now to ask, I will be also more than happy to, and pretty much if also I would like to let there my contact information, just if someone want to make any question after all. So
Oscar, that was fantastic. Don't put your email there, because I always send you emails. You remember that with question to your articles and to the abutments, which are sometimes constructed. Send him an email. He's the absolute expert. So, Oscar, that was amazing. That was so great. I loved it. I learned again so much. I will change everything tomorrow. Thank you very much. On behalf of the AAO, people are applauding you from all around the world, saying thank you, Oscar. You can read that later. Very, very nice presentation. All your work, it's just amazing how you do it. I really congratulate you for your work.
Thank you so much.
Oscar, there are some questions, but I think a lot of people, they just listen to us and they didn't punch so much questions. There's one question which I actually like. There's the book of Inaki Gamborena behind you. What kind of impact did his concept have for you? He's asked by Maximiliano. I think it's a nice question.
The impact
of his work and probably also his prosthetic work or sort of how he does his prosthetics.
Of course, I respect Iñaki very, very much. Although we have few difference in the way we approach the prosthetic part,
yes,
but his work is absolutely excellent. For example, he compensates with soft tissues, especially from the tuberosity, a lot, and And of course, we go for this area too. We learn that from him pretty much. But then there is also a few difference in the way we play with the soft tissues from time to time. Although we have a lot of very healthy discussions between us in order to to put and to grow in those particular concepts. But of course, he's a master, so I respect him very, very much.
Yeah. Thank you. Oscar, I think one more question. We're already over time. People applaud you and say thank you. It's always a little bit tradition here that the last question belongs to me. And I have maybe one more question, which you maybe already a little bit commented on, but I want to make it a little more clear. You said, let's talk again about tie bases, about the height of the tie bases. I'm not sure if it really came completely clear. You talked about width of the tie base. I again would like to emphasize it. You normally use a very, very shallow tie base to have enough room to play with the soft tissues. Is that correct? Or are there also situations where you use a higher tie base, so titanium compartment of it? We're talking about 1 millimeter, which should be the normal one or the standard one. Are there indications where you also use a 2 or 3 millimeter height of tie base and then start with the zirconia? Maybe to clarify it a little bit for me, because this is a very important point for me.
Sure. The shorter I use is 1.5. That's the shorter. The first thing we have to think is how much is the space that the connective tissue need to be respected. So depending what you read, between 1.2 to 2 millimeters, that's what you need for the soft tissue, for the connective tissue to be stable. It's a matter of is an aesthetic zone or is not an aesthetic zone. If we focus in the aesthetic zone, I will use the minimal as possible, but never less than 1.5. Never
Oscar,
less.
But does that also account for situation? I had Thomas Linkevicius here placing implants very, very deep. Does that also account if you start with your tie base subcrestal?
Yeah. The question is
the hard question at the end. I'm sorry.
I know that question because we were discussing about that before.
I know.
The question is, I like I cannot prove it, but I like to have the titanium above of the buccal plate. And then you say, okay, the buccal plate. Why the buccal plate and not the palatal plate or the interproximal? Because most of the time you have an scalloping. Yes, you choose to be above the concavity of the scalloping on the buccal plate. But most of the time you will be below the bone interproximal or to the palate.
Anyway, right. Mm-hmm.
But the buccal plate is the only one which is not supported by either the tooth or the palate, which is quite a strong structure. So in my humble opinion, I think it's more critical to create an issue on the buccal plate that on the other two areas that we don't see much problems when the platform is not above the interproximal bone, for example, bony peaks. So yes, I prefer to have the platform, the titanium platform, never inside of the buccal plate scenario.
And to be honest, Oscar, I prefer to have the implant not so deep.
No, of course. that
I'm a periodontist, so.
No, that's true. No, but it's true. It's true.
Oscar, that was fantastic. I love you. It was a great presentation. I am a fan of your work. I'm a fan of you as a person. And now, as I heard, you're writing a book for children. It's great. And he contributes all the money to good things. So buy this book. I will be also the first one buying this book. Oscar, on behalf of the EAO, the president was also here tonight. He applauds you. Thank you for making this possible. I know you have a very, very tight schedule, just came in from US. Thank you on behalf of the EAO. Thank you on behalf of everyone who was listening and watching. It was a true pleasure. I enjoyed it so much. I just want to say, everyone who is interested in education, we have an annual congress next year in Monaco. Oscar will be there definitely. There's a pre-registration rate, so if you want to save a little bit money, there's also a chance to register already for the next annual congress. And with this, I would like to say thank you again to Oscar. Thanks all around the world. Merry Christmas, and we'll see everyone next year. Oscar, the last words are to you.
Thank you to the EAO. Thank you, because you make it so simple, so easy for me, and I really enjoy that. And thank you to everyone who has taken the time to listen to us. And I wish you all Merry Christmas, and I hope to see you around. Okay. Thank you so much.
Ciao.
Ciao.